Good morning, good afternoon, good evening, everyone, wherever you are. And welcome to this TechNet webinar session on early lessons from Ethiopia in establishing a data triangulation process to analyze immunization program and supply data for decision making. I'm really happy to welcome our guests today. This session is recorded and we're going to share the video and the links to the presentation later after the session. Please ask your questions in the Q&A box as soon as you want during the presentation. And we should have some time at the end of the presentation to answer questions. And for people who speak French, the session is interpreted. So I'm going to explain in French how to do it. Pour les personnes qui souhaiteraient écouter la session en français, cliquez en bas de la fenêtre sur Interprétation et choisissez Français. Vous pouvez aussi couper le son d'origine pour pouvoir mieux entendre, pour le confort d'écoute. All the recordings will be shared in English and French later on. I will give now the floor to Adriana. Adriana.
Sure. Maybe just before we start, I think that someone has written that the chat is disabled. So if we can check on that before we get started.
Oh, yes, please enable the chat so we can type where we're joining from and who we are. Thank you.
The chat is sorry, the chat is actually enabled.
Hmm.
So anyone would like to try to write something in the chat, please?
Yeah.
Yes, it's working. At least it's working for we receive messages, but it's not shared to everyone. So please, if you want to share the messages with everyone, select in the drop-down menu, select everyone or all. Thank you.
It's not coming up for me and everyone option. I don't know if that's others are having that same issue.
Okay, let me look into the system and I will try to fix that. Thank you.
Okay, great. Thanks, everyone. Maybe we'll get started while we're working on that. So hi, everyone. Good morning, afternoon, evening. Thanks for joining today. Today we wanted to present out an experience, early lessons from Ethiopia in establishing a data triangulation process to analyze immunization program and supply data for decision making. So we'll have 3 speakers today. We are joined today by Johannes Laku. He's the EPI program manager and the assistant director for the Maternal and Child Health Directorate with the Ministry of Health in Ethiopia. We have Amare Baye, who's a senior technical advisor currently at PATH, and myself, I'm Adriana Almignana, and I'm an immunization technical advisor with JSI based in the US. So first, I will hand it over to Johannes, who will help give us the landscape of EPI in Ethiopia, as well as immunization data issues in the country. Welcome, Johannes.
Thank you very much, Adriana. It's my pleasure to present you the context of the immunization program, as well as the data management, how we are working on immunization area. So I wish you will enjoy my presentation. Next slide, please. Thank you very much. So I do have a very short presentation for you. I will show you the Ethiopian immunization background, the core performance indicator on the immunization, immunization data management as well. And I can also share you some major successes through this 43 years of immunization program. And later on, I will show you the challenges and the way forward that we are working so far. So with this, I will try to frame my presentation based on the outlines. Next slide. Thank you very much. So when you see the, Ethiopia is a country located in the Horn of Africa, basically East Africa. So we do have a very big population in Africa. We are the second most populous country. We do have an administrative structure which is, organized through regional states. We have around 11 regional states and 2 city administration, which are independent out of these 11. And each region also really clustered within zones. We call it zone actually. So around 115 zonal clusters are there within this 13 regional administration. Within this zonal administration also, we do have also more than 1,000 districts, we call it Werada. So where majority of our population are also living in the rural areas where the infrastructures are really challenging, like road, electricity, clean water supply is basically a challenge. Geographically also, it's a big country. Coming to the health infrastructure, we do have more than around 395 hospitals, 3,700 health centers, and more than around 18,000 health posters. We do have a national and regional laboratories especially for vaccine preventable disease, especially when there is an outbreak confirmation. We do use these national and regional laboratories to do an investigation for an epidemiological cases. And we do have also national and subnational pharmaceutical supply service agencies, where those vaccines and the logistics are distributed to the subnational, to the health facilities. And in general, we do have more than 21,000 health facilities are currently providing the immunization service. In all areas like hospitals, health centers, and health posts in general, the immunization service has been provided for our children in the community. Next slide. To give you, over and highlight on the health sector operating structures, actually we can divide it into two: the coordination platform as well as the service delivery modality. Actually, Ethiopia is using the 3-tier system of health service provision: the primary level care, the secondary care, and the tertiary level cares. In the primary health care service, we do have health posts, health center, and the primary hospitals, where the major immunization service were provided in the primary health care level. Even in the second level, so it will be provided, but the number is also quite minimal. Under tertiary level, almost more advanced or complicated cases were managed in specialized hospitals as well. When you see the coordination system have around 4 levels: the national immunization program, the regional state immunization coordination levels, which is led by the EPI team or focal person will be there. At the zonal level, we do have also EPI focals, Werada levels, EPI focals, and at the lower or the lowest administrative level, we call it Kabale, where health extension workers and human community health development army were the lowest coordinating the immunization program. Next slide. So when you see the immunization portfolio, as I mentioned, it was commenced 43 years back, around 1918. We launched with 6 antigen. Then since 2007 to 2020, we introduced a lot of vaccine, like Penta. We changed actually the DPT to 5 antigens. PCV was introduced, IPV. Polio transition was also made from trivalent to bivalent. HPV vaccine was introduced in 2018. MCV2 vaccine also introduced in 2019. In 2020, we do also manage to switch from tetanus toxoid to tetanus diphtheria. As well, PCV10 serotype vaccine was also changed to PCV13 serotype vaccine, and recently we also introduced the COVID vaccines for outbreak for the pandemic response as well. Next slide. So to show the major indicators, and even to show you how much we are reducing the mortalities across over the years. Since 2005 Gregorian calendar, where the under 5 mortality and infant mortality is too much high. When you see in the 2019, we managed to reduce it almost more than by half. So this is a tremendous effort that was made in immunization and other child health service. So we think that the immunization service contributed a lot in reducing infant and under 5 mortality, because most of the cases that we have as a country is infectious disease, which are vaccine preventable. So with the efforts of the immunization program, we managed to reduce these amounts of infant and under 5 mortality. So the trend shows that still we are progressing too much, but there are also a lot of things need to be done to reduce it to acceptable ranges. If you can see also the immunization coverage across all the years since 2000, since the millennium of the Gregorian calendar, the immunization coverage like Penta3 increased from 21% to 61%. So this is, the efforts of, many stakeholders has been contributed for the achievement of such an increase. Despite, however, this coverage is still suboptimal, and we need to work more and more to increase the coverage. Next. Next. All right. So, we are also looking at the data for decision making. So one of the things that we are critically looking at is, zero dose children, because this is one of the global agenda, and it's also our agenda. So using the recent demographic health survey conducted in our country, we are locating, where these zero dose are, really residing. So across all the regions, we try to map it. So one of the regions, like pastoral regions that we have, like Somali, Afar, Gambela, where we have a lot of unvaccinated or zero dose children. So like Addis Ababa and the Redwa or Tigray region have a good in terms of addressing the zero dose children, but the rest of the regions will really requires a lot of investment and activities to improve the zero dose. So Ethiopia is also contributing a lot of zero dose for the global community as well. Next slide. So in terms of immunization data management, actually as a ministry, as a country, we do have Health Information Technology Directorate, we call it HITD, and there are corresponding, directorates at the subnational levels who are really managing the health information system. And at the same time, we do have also a policy plan and a monitoring evaluation directorate, which oversees the data of the immunization. So these two entities with a program, peoples like me, we are looking at the data of the immunization. And additionally, we do have also surveillance data from another institution, agency under the ministry. We call it Ethiopian Public Health Institute, the ones they are doing on the surveillance and other data. So these 4 entities really providing and analyzing immunization data for decision making. So Ethiopia also designed and has implemented health management information system. We call it HMIS, where the ECHIS and the CHIS program also implemented in the health post level to capture the data at the Kabale level. So data is one of the biggest issue in our ministry, and even in the previous strategic period, it is one of the 4 pillar of the ministry is working for. And even in the coming 5 years, the ministry also point out, the information revolution has to be taken place in our country to improve the use of data and increase the use of data culture, so that this is one of the biggest agenda, and everyone in the ministry also has to contribute for improvement of data utilization, data management, and other issues. Recently, we also utilized a DHIS2 platform, to facilitate, the data system in our country, to improve the data quality, to improve the visualization, and other issues also can be addressed through the DHIS2 platform. This is one of the global tool that has been used for many years to improve the immunization data as well as other health informations. So these are the basic coordinating team. The ministry have given a lot of emphasis for this, and the immunization program is one of the we call it tracer for health system, so that most of the indicators that are addressed through the DHIS2 platform is the immunization indicators are there. So these are the issues. And next slide, please. So as a ministry, we are using different data sources, to make a decision. We use the administrative data, which comes every month from the lower level and collected through the DHIS2 platform. And we will also use a coverage surveys that has been conducted by different bodies like the ministry, universities, and other coverage surveys also used for EPI data decision making. DHIS demographic health surveys, it can be also conducted within 5 years one time. So we're also utilizing this data as one of the EPI data. WINEC also one of the estimations that we are using so far. So considering all this data, we are as a ministry try to decide based on the evidences to improve the immunization program. So these are the basic data that has been used and will be used for the future to improve the program and to make an evidence-based decision making. Next slide. This is to show you the coverage performance across many years by triangulating through different data sources, which I have mentioned already, like coverage survey, demographic health survey, WINEC. The admin data has been clearly here. One of the surprising issues, we do have a very big data discrepancies across different data sources. If you can see, for example, the 2019 the mini DHS demographic health survey data, and compare it with the admin data, it's the difference is too much big. It might be different reasons actually, but in general, what we can see from this graph is, as the immunization community, we do have a data discrepancy across all different estimates. So in the future, we are working to narrow the differences to be correct and reliable on our decisions. So this is one of our findings while we are triangulating our different data sources. So for our case, for decision making, we are triangulating this data to be realistic on our decisions. So this is one of the triangulation exercise that we are doing as a ministry regularly every time. Next slide. The other issue that we are also triangulating and looking is for decision making is, we are triangulating the coverage data with the logistics distributed to the subnationals. Actually, this may not be realistic, but it shows you some information. For example, if you look at Somali region, which have the highest discrepancy within the logistics as well as the routine administrative data. Actually, this is the coverage is higher than the logistics. So it's surprising for us as well while we're analyzing this data. Further, it requires a detailed interpretation and analysis. But in general, such kinds of analysis may help you to zoom in to look at the actual problem on the ground. So this is also one of the triangulation that we are exercising as a ministry for policy making and even devising strategies and activities as well. Next slide. When you come to, in general, the immunization program success, as I mentioned, the immunization program almost it's becoming an old man. So with this more than 43 years of journey, we try to, achieve like polio-free status since 2014. We have already eradicated as a country, despite the current challenges of CVD-PV. We also eliminated, maternal and neonatal tetanus. Similarly, we also managed to vaccinate measles in the midst of, the COVID pandemic in 2020. We conducted in July 2022, where everybody closed his, doors for any service. So at that time, as a ministry, the political decision, the program partners together, we decided to conduct that measles SI in the midst of the COVID-19. This can be also taken as a big success, where that situation doesn't allow you to do any service for the community. We also conducted a successive COVID-19 vaccination campaigns. So far, we managed to vaccinate more than 52 million doses were administered to our people. This is also a huge success for our case, especially when you have such a big conflict, drought, and outstanding health system challenge. So it can be also considered as a big success because most African countries can't even manage to do this amount of vaccination so far. There are a lot of infrastructure improvements within these 40 years of journey. We provided different online trainings using the opportunity of this COVID has also taught us to use a virtual platform as well. DHIS to also adapted for COVID data management as well. We are starting it recently. Taking us adapting this DHIS2 for COVID, it can be also taken as an success, but it even requires a lot of investment so far to improve it. But taking this initiative and introducing this DHIS2 for COVID also can be taken as a success because we are trying to roll out it as a countrywide. Performance monitoring team also established at all levels, including health facilities, to really look at their own data and make a decision at their own level to improve the program. So this PMT team will have a regular meeting. They will set up an action point. They will take a correction accordingly, even though the performance at the lower levels, have this, different levels, different maturity levels. But this performance monitoring team is already established in almost all health facilities. That's a good initiation, but we need to capitalize on that to improve, to the moment that we need it. The other issue is the data quality audit using a load quality assurance method. So regularly, this also done at the lower level, even by the district levels. Also doing this is quarterly for the health facilities. They will check the data who are on the ground. Later on, defaulted tracking and the different monitoring system also utilized to improve the immunization system, like monitoring the immunization performance through EPI monitoring charts also can be taken as a success. But when I say a success, we need to also work on sustainability and using regularly in all levels. Data triangulation practices at different levels also started, and this can be also capitalized more. Next slide. So when it comes to challenge, I actually tried to mention it in the previous slides. We recently, as a country, we faced a security challenge, a huge, drought, the COVID pandemic is a global challenge. Different outbreaks in our country, like measles, cholera, whatever. This also can, overwhelm the health, health system as well. High turnover of staffs at different levels. When it takes to COVID, we do have also a challenge of vaccine instance in urban areas, especially. Infrastructure connectivity, and availability of infrastructure like computers and others also really a challenge, especially for data and triangulations as well, because we're in areas you don't have any connectivity and the computers. We used we don't use digital systems, so that information that we are getting from those areas is not real time, and you cannot make a decision timely, so that connectivity and infrastructure challenges are still persist as an outstanding challenge for us, and it's really threaten us, not to improve, the immunization data. Shortage of data recording tools at the facility is one of the issue. Probably in the next presentation, it might be also mentioned. Reporting consistency delays due to the connectivity and turnover of staff and other issue also can be also a challenge as well. Uncertainty of our population estimates, especially we have a long we conducted the census in 2007, and it has been a long time, and still our population estimate may not be realistic on the ground, to do analysis and other to take informed decisions, so that a population estimate is also one of our challenge. Lack of real-time data due to different reasons, connectivity, computers, whatever. So we still lack having real-time data for decisions. Data visibility at the district levels, especially for logistics. So far, we have a visibility to the subnational hub level, which is one step from the national. But at the third level, at the fourth level of structure, we haven't have a visibility to take action as well. So these are the common challenge that we have as a country. These are the biggest one. When you go down, there might be a loss of detailed challenges. As a way forward, as a country, we are trying to mitigate all these challenges, even though we didn't achieve as per our need. We conducted a catch-up campaigns in a conflict and the drought-affected areas to address zero dose. We are also continuing demand creation and advocacy for increase awareness of our people to get the vaccine. We continue the resource mobilization, strengthen our supportive supervision. We are working even the triangulation to do it continuously because of the issue of the data discrepancy across all estimates. Integration of service and reduce missed opportunity. This is one of the issues that we have, and we are working on this. Digitalization is one of the issues to get a real-time data, to get accurate data, to have a visualization, and so many things can be addressed through digitalization as well. So these are commonly as a general that we are working forward in the future to improve the data and even the service as well. Next. This is one of the pictures really how our health workers are striving to address vaccine for inaccessible areas. So it's really an adventure for me to go through these hills and to reach unreached community, and we much appreciate our health workers who are working on the ground to improve the immunization coverage at all levels. So as a country, we will work within this condition. There are also different pictures for the time being that I can't really show for you. Next. So this is in general the highlights of the immunization program and the data triangulation that we are exercising so far. And we really thank you for your time and attention. If there are any comments, suggestions, please welcome. And at the end, I would like to call upon all stakeholders who are attending this meeting to be, an advocate for immunization program improvement in Ethiopia, especially on the way forward that I mentioned, because we need a support from partners, stakeholders, be it in a technical way, be it in a resource, in whatever way we need your support. And thank you for your time. If I may take a lot of time, please apologize me. Thank you.
Great. Thank you so much, Johannes. Now I'm going to pass it over to my colleague Mare, who will start us off talking about our project's experience in establishing a data triangulation process to look at both program and supply data at subnational level. Mare?
Thank you, Ariana. So can you share us the slide screen? Hello, Ariana?
Yes.
So,
okay.
Yeah, please share the screen.
Can you see?
Not yet.
Am I sharing still
Yes.
for everyone in the call?
Yes,
Yes.
you're sharing, Adriana. Amare, you might have some technical issues on your side. Can I help you?
So the host disabled the participant screen sharing. So I think it's your side.
Can you see? Can you see the slides that Adriana is showing?
No, I just am seeing your name.
Okay, so at the top of your screen, top right, there should be an icon that's where you can change what you can see. Can you see it?
Now it's coming. Okay.
Yes, your sound is not too good now, Amare.
Are you able to see the background slide now?
No. Yes. Okay, now I can see it.
Okay, good.
Great.
Okay. Okay, sorry for the inconvenience. Hi, everyone. My name is Amara Panya. I'm part of this, I was part of this activity, so I will share some of the activities that was done just to do data triangulation at subnational level. So as Johannes was mentioning, there are data sources at the national as well as subnational level, the LMIS and EPI data through MRAN, that's a mobile locally created mobile system, and the DHIS2 through the planning department. So actually, practically, there is a lot of challenges to improve data. Still, there was challenge on quality, timeliness, and completeness, and there is limited data sharing between these two big departments in the Ministry of Health regarding to the immunization program. Mainly the EPI program data is the responsibilities for EPI officers, but during reviewing, there is no leverage of using supply chain data to leverage decision making.
Amare,
Yes.
sorry to interrupt you. Your sound is really, there's a lot of echo. The sound is really bad. Is there a way you can, do you have like a headset or something close to you? Hello?
What about now?
Oh, it's much better. Thank you very much. This is great. Thank you.
Okay, great. So the second is due to this challenge, JSI with the Ministry of Health and partners and other experts, they conducted a consultative workshop just to identify what are the real bottlenecks and how can we tackle those bottlenecks to improve that's data sharing between the departments, as well as how to identify the challenges between these two data sources, how to bring together these data sources for program improvement. So the workshop just focused on identifying and listing of short list of indicators that would be analyzed every month. And once the indicator is developed and suggested actions was also developed depending on the data. For actually, we identified 6 key indicators. For example, these are the 2 indicators as you see from this slide. So every month, the team, they enter those data. And for example, here, 135 doses administered and doses issued. So the ratio between these 2 indicators indicates 1.1 to 5. So the team or the tool automatically interprets this, and the assumption or the interpretation is it's close to 1. But if the ratio is greater than 1, it may indicate data quality issues or over-reporting of doses administered. So automatically the tool generates potential solutions, like investigates the reasons why such problem happened at district level, and also how to improve, or the team remotely communicate with the districts, as well as they have a plan just to provide support to supervision, just to identify the root cause and improve accurate reporting. Next. So this is the steps how the team, they bring this big data sources into one. So this Ethiopian pharmaceutical supply agency is responsible all immunization supply data, and DHIS2 is for immunization program data. So this is a big department. So bring this data from these 2 sources. So the immunization officer is responsible just and receives this data every month from these 2 departments. And then they import into the immunization data triangulation tool. It's an Excel-based tool which is designed for this purpose. And then automatically this tool generates key calculations, and also it colors the type of the level of the findings, like green, yellow, red, and then generates some suggested solutions. And then based on that finding, the team will meet together and review the dashboard and discuss what is the source of in which, is it supply side or the immunization program data, and then they discuss how to address identify the action items and address the issues. And then finally, they took their share, the planning department or the DHIS2 department from the program data and the HMIS, the supply chain officer takes issues related to supply data, and the immunization program officer coordinates overall. At the same time, he also takes important technical issues just to address. So based on this, there are a lot of issues that observed, like
important outcomes like increased coverage, decreased dropout rate, improve the coordination and data sharing between these two departments. And there is also an important activity for decision making, for supervision, for planning, review meeting, and so on. So this activity will be in cycles that we continue in every month, and every month they usually see the progress of the previous action points and then review for the current month. So these are the most important things. And the other, throughout this process, we also provide documentation on lessons learned, how it going on, how the team reviews, how it is applicable and transferred to other regions was one of the issues that was happened. So the process documentation, objective, and methods was the objective was to understand the feasibility of this data triangulation application for decision making, like among different departments, and decisions made on the data analysis and the actions taken, and what was the outcomes of those actions was the objective of this documentation process. So the method was actually mainly qualitative method, including key informant interview at both IPSA, Regional Health Bureau, Health Management Information System, and other officials, and GSI project staffs who continuously supporting those regions on a monthly basis meeting. So this was conducted in two regions, in Benshangul Gunz and the SNNPR in one of the zones. So the method was just to examine and the data upload to the data triangulation tool and review the meeting notes over the period of implementation to track the data being uploaded, and the decisions were made as a result of the data review. So this is one of the issues. So I think I will hand over to you, Ariana. Thank you.
Great, thanks, Amare. Okay, so I'm going to move us right along into findings. Okay, so findings. So as Amare mentioned, we implemented this in two areas. And what did we find? So we found that you know, one of the two places where we introduced this demonstrated faster uptake of the tool and the approach. You know, they were using the tool regularly for decision making. They were having their review meetings every month, and over time they had increasing ease of using the tool. They were mastering, you know, how to import the data, looking at the dashboards, and just kind of getting used to the whole process over time. The committee members, which again were staff who were focused on EPI, on supply chain, and on the DHIS2 system. So these were staff that normally are working across different departments. They were interacting with the data as well as each other often, and they were looking at this data holistically. So they, you know, noted that this kind of simultaneous review of coverage and supply chain data was a new process, and it was something that they really saw a lot of value in that. So what else happened in another area that where this was implemented? They saw bigger challenges as well as a slower rollout. So around the time of introduction and in the 6 months prior to introduction, there were issues in one area with recurring conflict, competing priorities, and this was in 2020. So they were also experiencing some major waves of COVID-19. And this really limited the staff's ability to engage in the implementation. and more importantly, it affected the availability of data. So, I mean, these issues were broad. They were affecting, you know, the functionality and the performance of Benchangul Gumuz's immunization program as a whole. And, you know, it obviously, it also caused a delay in this activities implementation. So because, you know, the availability of data suffered because reporting to the systems had suffered basically in the 6 months prior due to all of those issues, particularly on the supply chain side, so the Mbrana data, but also in areas of conflict, DHIS2 data availability was also affected. So before the activity started in this region, you know, the stakeholders at regional level took steps to improve just basic data completeness. And this was needed in order to ensure that you know, that data was available, and then to begin to actually triangulate and analyze across data systems. So this was an ongoing process, right? Like there was some work up front, and it continued throughout implementation. And you know, we did encourage staff to just start with the data that they did have, and start to get used to looking at triangulated data on a regular basis. So I'm just going to quickly share a couple of documented outcomes. One in one area was increased number of outreach sites. So the data triangulation team looked at, they noticed that there was low coverage in one area despite there being adequate vaccine supply. So they, you know, went to the town, they communicated with the EPI officers there, and they identified the reasons, which is essentially, it was a combination of poor planning as well as an outreach, a shortage of outreach sites. So in collaboration with that town, the managers helped launch new outreach sites in that area. In another documented outcome, there was a small town in an urban area that was having relatively poor performance compared to neighboring areas. The action to take was to conduct supportive supervision there, and they realized that some of the neighboring communities had actually been rezoned into the town. And so, you know, essentially the outcome of that was that you know, the EPI office in that town essentially recognized and had to revise their target population, excuse me, and adjust their microplan in order to plan to reach these areas that they were now responsible for. And so I know we're short on time and we want to have some time for questions. So I'm going to take us through some lessons learned quickly. So first, some lessons learned around establishing regular processes for using triangulated data in immunization. So first, triangulation can foster better coordination among health staff with different professional roles. So this was really important to analyze data from different perspectives, to encourage that group problem solving. We were getting people in the same room that maybe didn't necessarily get together as regularly to talk about these issues. Secondly, this one might be obvious, but a regular availability of data is important to fully leverage the benefits of triangulation. So you have to ensure that the regular reporting of data is going to continue to happen, right? Even in times of crisis. There has to be efforts to improve and sustain, you know, basic data availability and completeness. We find that it continues to be an important issue that needs to be prioritized. And then lastly, subnational managers, so regional, provincial managers, could use data triangulation to monitor issues at the district level. Given that, data triangulation can sometimes be perceived as a bit complex. We found that having these regional level managers using data triangulation as a management tool at the regional level to basically address problems happening at the district level, that showed some success. It takes ongoing practice, support, but we found that it really helped pinpoint management support to the districts. All right, and then introducing tools and processes into health systems. So some guidelines around this. So first, designing with and for the users. As we mentioned before, the stakeholders were engaged from the very beginning to help us co-design this tool with features that would address their needs. We needed to take some of the work out of triangulation. So a lot of that kind of back end merging of data sets and analyzing the data, it needed to be done automatically to the extent possible to make it easy enough of a lift to do it monthly, right? These are folks who are already busy. So it needed to be something that was light enough and feasible to implement within their kind of busy day-to-day. Secondly, manage change and encourage new practices through frequent follow-up support. So our project staff that were supporting this activity, they were seconded to these regional offices just as part of our overall project approach. So they were in regular contact and they could provide kind of overall mentorship on the whole process over time, and play that facilitation role and mentorship role. Third, embed implementation research into introduction processes. We found that this was really, really important. It helped provide valuable information on basically, on what's working, what wasn't, and then what could we adapt or improve. And then lastly, maybe arguably the most important, don't let perfect be the enemy of the good. As regular reporting had lapsed in some places before startup, affecting the availability of data, we really found that despite this limitation, encouraging folks to start using the data that you have available while working to improve overall data availability at the same time. Getting started with that imperfect data allows that collaboration to start happening, that increased comfort and capacity to use and analyze the data, and then to begin to take action to address some problems. Okay, and then I won't spend too much time on recommendations. We have a lot. I think this was certainly a pilot activity. We were testing out what might work, and this was just one approach to data triangulation, making it a regular process at subnational level. But we think more research and documentation is certainly needed. And so what we think is really still needed is again, what can that regular practical data triangulation process look like at country level and at subnational level? So the approach we took was one, but there's lots of different ways you can think about doing this, and lots of different ways that might work. More evidence around how these processes contribute to better decision making and better data quality. And then I think there's also something to say about relevant indicators and analyses that are most useful for EPI. Some of the real details around it, things like, do rolling averages make more sense, or different, some of those really specific details that I think we could do a bit more work on. And then just quickly, well, I think the rest of the recommendations here are kind of covered under some of the lessons learned, but really just thinking about what's practical, what's feasible. And then as they advance and scale, they should be really integrated into current health information systems, right? In order to really be able to kind of routinize and sustain this kind of process. Great. And I think I've basically covered, in conclusion, I think, like I said, this was just one approach that we took to try and help routinize the use of triangulated data for immunization. I think we had some limitations in data availability, but we had some really good promising lessons and promising practices that were starting to form. And we did see that it did spur actions at lower level, and that respondents really found value in regularly using triangulated data.
Thank you so much. Sorry.
Yes, thank you.
Yes, we have 4 minutes for questions. And,
yes, sorry.
No, super. Thank you. And if I can take the mic, well, I want to thank the audience because we ended up with more than 80 people joining us today. And I'll take advantage of having the mic to ask, what does it take in terms of resources to establish these data improvement working groups or the data action groups? I don't know what's the catchy name, but if countries want to start implementing this, what would it take for them? And then Alex will ask questions in the chat and in the Q&A. Thank you.
Yeah, sure. So maybe I can just start quickly and see if my colleagues have any other thoughts to add. I think, it really depends, right? So what we wanted to do was to, make this kind of a monthly process where we were bringing folks together. And there was a lot of emphasis on kind of trying to take that, that work out of, kind of the manual merging of data that needs to happen. And a lot of that is particular to the way that that these different information systems are set up currently in Ethiopia. So I think it's a bit of a difficult question to answer because I think it will depend on each country and what their data systems look like, what level of integration might already be there or not. But I think what's clear is that kind of having that initial work to figure out, what's the way that we're going to go about doing this. Who is going to be responsible for bringing these data together every month, organizing this kind of cross-departmental group to come together. Maybe in some countries that's already happening, right? So maybe it's just kind of, in various stages of maturity. So I think there needs to be that kind of discussion up front and probably some technical assistance to kind of figure that out and then provide some ongoing support. So I could see it going different ways, right? We kind of provided this activity actually, it was towards the end of our project. So we actually really were not able to implement as long as we would have liked. But I think if you had more time, you could think about once you've tested this out, how can you make some integration in terms of the information systems, that's obviously that's a longer term process, but I think there's different ways to go about it. Obviously, some lighter touch than others. I don't know if others have thoughts.
Maybe we can pass to the questions in the Q&A, Alex, if you can read them all together because we have only a minute.
Yes,
yeah, we have a minute. So Adriana, I don't know if you can see the Q&A questions. The questions in the Q&A section. Perhaps I'll let you choose the most, what you think is the most, they're probably all important and relevant, but I'll let you choose your preferred one.
Yeah, sure. So I'm just looking quickly at Tewodros Balaina's question is, was there issues of data quality faced? How did you try to ensure the source's data quality before triangulation? This is a really important point. And yes, so I mean, that is like a regular function of what each of these teams should already be doing, right? So we did make sure that there were some of these quality checks happening regularly before we merge these the HMIS and LMIS data to look at and triangulate together. So that's why kind of doing this on a monthly process was maybe the most frequent that we could have done, just because there does take some time, and you always have some delays of people submitting data up the chain and whatnot. So we certainly did look at and try to address some of those quality issues before we did our triangulation exercises. And maybe, I know we're out of time. I'm so sorry that we ran a bit late, but I just wanted to maybe just thank everyone for coming. Maybe I can quickly say that we do have a journal article that we can share, maybe the link to that, as well as the slides afterwards. And my contact information is here as well, if anyone would like to reach out and chat further.
Great, thank you, Adriana. I would suggest you send me everything because I'm going to send an email to everyone who registered here with the links to the presentation in English, the recording in English and in French. And I see that Lisa proposed to answer questions offline, so
Yes,
we can collect the three
too.
remaining questions, and we can answer those questions by email. So I'll send an email to everyone. Probably next week, because it will take some time for our colleagues to answer the questions. And then early next week, you'll have everything in your mailbox. So thank you, Adriana. Thank you, everyone who participated to this excellent presentation. And I'm actually pleasantly surprised to see so many people. So thank you, Adriana.
Thank you.
Thank you, Carolina. Thank you.
Thank you, Alex.
Yes.
Can we leave the line open for 3 more minutes for people to type their questions?
Yes, so you have 2-3 minutes to type your questions. Please go ahead. We can wrap up anyway, but I'm going to leave the line open for 2-3 minutes if you have more questions. So go ahead, ask your questions in the Q&A box, or even in the chat if it's easier for you. I will make sure that we can collect everything. Thank you, Adriana. Thank you, Johannes.
Thank you, everyone.
Thanks, everyone.
Thank you, Theodoros.
Thank you.
Thank you,
Goodbye.
Carolina. Bye. Bye, everyone. Bye.
Thank you.